So here we are again talking about a return to healing, Andy Lazarus with Alan Roth. And we do these on early Sunday mornings. Um, so we can figure out all the things that happened to us during the week. And Alan, one interesting thing that happened, I have good friends who know a lot of the big dogs in Baltimore. And one of them bought our book, was absolutely loved our book. And by the way, a few people who bought our book have just been sending it out to everyone else, which is wonderful. But her, they have friends who actually run the medical school at Hopkins. And if you haven't read our book, and you should, Hopkins is both a target and an inspiration for our book. Because back in the day when Osler was running Hopkins in the early 1900s, they had the most innovative education system in the world. Students came there, first of all, most students who went there already had critical thinking skills because they went to undergraduate and learned things other than straight biology. They learn things that you're supposed to learn to keep your mind active. And then when they got there from day one, they were working with doctors in the community, seeing patients, not just the little plunge that they do now, but they were a deep dive in the community. They would spend hours every day with patients, and then they would go back to the classroom for a couple hours every day and learn about the pathophysiology, anatomy, science of the people they saw. And that's the system you and I would crave right now, not this division between 2 years of sitting in a classroom and then 2 years in a hospital. Because people never get out in the community and see what's actually going on. So this guy, the guy in charge of Hopkins says, well, we've revolutionized our system. We've made it like that now. And I know people who go to Hopkins Medical School. It's the same thing. It's the same thing I just described. You get a token visit with a patient once in a while, but otherwise you're sitting in a classroom learning mostly stuff you're going to forget. You get assessed by this huge marathon multiple choice test that most people study for months, hoping they'll survive it. And then you proceed to knock all that out of your brain because it is not correlated to any patient you've ever seen. So the only innovation I think they came up with Hopkins, based on the students I know, is that they teach the kids how to use ultrasounds, at least in a remedial way. These handheld ultrasound machines, they walk around and they could look at parts of your body and see what's what there as they're for reasons that may have nothing to do with why they're in the hospital. So what do you think about that, Alan? You
So,
teach students.
so I teach students, and I'm proud and embarrassed at the same time to say that we just purchased an $80,000 ultrasound unit for our residency program. But to be honest with you, we had no choice, and we had no choice because it's now in the ACGME. ACGME is the Accreditation Council for Graduate Medical Education, and they accredit residencies, say, in a primary care or family medicine residency training program, which takes the student from medical school and turns them into a primary care family doc. They must have this training. And, old folks like me and Andy laugh because, like, do you really need an ultrasound of someone's knee to stick a needle in their knee? Like, I've done joint aspirations and injections for 40 years now. I never needed an ultrasound to do it. And this is just another example of the technologicalization of medicine and the reliance on information technology. Because, you know, these are my residents. My residents walk around with their phone in front of their face all the time, and they're on either up to date or open evidence. Open evidence is you ask a question. So, the question would be, what do I do with a swollen knee? And get like 25 pages of what to do with a swollen knee. And ultimately, like, you needed a history and physical first, but they don't ask that part. They just do, like, what do you do with a swollen knee, because that's what's in front of them. So they don't have to think through the history, the physical exam, or anything like that. It's all in their phone. So we're taking critical thinking totally away from them. That's one part of this. And the other part is the technology. You don't need to examine people anymore. So, just do an ultrasound. But me and Andy know really well that, ultrasound in the hands of someone who's undertrained, which 99, a radiologist takes years for them to get certification in reading an ultrasound. They just put the machine on and start practicing. They find what we call incidentalomas, which is meaningless stuff, which leads to a CAT scan or an MRI because they did a test that they shouldn't have done to begin with. And that's, again, the cascade of overtesting, leading to overdiagnosis of meaningless things, leading to overtreatment and harm to the patient.
And this idea of testing people who don't have a likely diagnosis of something. Again, critical thinking skills and a history, and to give an orthopedist credit, my nephew several years ago, who plays lacrosse, developed a severely swollen knee. And the orthopedist sat down and spoke with him and found out he's in the woods a lot and says, you know what, sometimes Lyme disease can do this. So let's check you for Lyme disease. And he did. That's what he had. The people who saw him before this orthopedist were putting needles in, sucking fluid out. They didn't know it, throwing up their heads. Maybe we need to scope it. Maybe we need an MRI. But this orthopedist asked a question. And often in our world, that's all it takes is talking to someone. And again, this was Osler. If you want to know what's wrong with the patient, ask the patient. That's number one. Well, in my world, when people go to the emergency room, they're just hit by a litany of tests, especially if they're over the age of 70. Tests that mean nothing. They could go in with toe pain and get tests for congestive heart failure, for heart attacks. And often those tests are positive because, as we wrote about in several articles, older people tend to have more positive tests than younger people because they have muscle destruction, other things that make these tests positive. And then they go down a train. They came in with toe pain, and the next thing they know, they're getting catheterized, they get stents, they're seeing 12 specialists, they're on 8 new medicines, and they come back to us and say, well, look, they saved my life. Thank God
Yeah.
I had the toe pain because now I have all this stuff, but I still have the toe pain, because they don't talk to the patient at all. And I just saw a patient recently, and by the way, this happened to my dad too, where he had a blood test because he was old and showed up in the emergency room called a BNP, which is a test for fluid overload and congestive heart failure. This patient was severely dehydrated but had a high BNP. Because they had a high BNP, the doctors felt they were fluid overloaded. So they started taking fluid off the patient. Patient's blood pressure dropped. Um, they got sicker, which led to new tests and new specialists. But really, doing a test inappropriately sends us down a road of more harm. And that's actually what the system we're living in right now. And that's what these ultrasounds will do, like so many other things.
And I see it with my patients that go to the ER every day, and we laugh about the toe pain, but it's kind of true. So there's three tests that my ER does on almost 90% of the adults that come in there. Okay, one is a troponin, which is used to look at heart damage. Okay, one is a BNP, which is looked for heart failure, and the other is a D dimer, which is looking at blood clots. If we do those three tests on me and Andy right now, something's going to be elevated on one of them. And we're going to either end up, like you said, with a cardiac cath or a CT pulmonary angiogram to rule out a PE, because there's a realm of norm in these tests. And, a little bump on one of these tests is absolutely meaningless, but not to the ER doc who already called, the cardiologist or the pulmonologist before calling the primary care team, even.
And by the way, they never called the primary care team. In my world, because I'm not in an academic center, we as primary care doctors are not allowed in the hospital. We've been banned from the hospital. And the reason is that they prefer to hire hospitalists because when we were there, we wouldn't refer to all the specialists, do all the tests, and feed them money. The hospitalists, and my son's going to become one in about a week. And he just came out of residency. So, I mean, he certainly doesn't have the breadth of knowledge and experience that we do. He's a good guy, but short of that, he's going to call the specialist in and he's going to get a lot of tests because that's what they're supposed to do. So each test has the possibility of having a false positive. And as you get older, that increases. In fact, there was an article recently, and I forget who wrote it. It was in the New Yorker, I think, about the total body MRI. Because my dad always said we should all get an MRI every day, the total body, and 'cause that's why he dived into the depths of the medical system, which harmed him greatly. But this article basically said what we know, which is the more testing you do blindly, the more what we call screening, um, in a way that the screening means you do a test without symptoms, the more false positives you're going to find. And this article estimated that if we did a total MRI on everyone, not only would it escalate the cost of care by hundreds of billions of dollars, but we'd end up killing people. And a lot of people don't understand that if we find things and try to fix them, every intervention we have has a certain percentage chance of hurting you. Like Alan said last week, when you do a catheterization on someone, you could clot off the artery and kill a leg. You could also cause a stroke, which is about 1% of people. That's no laughing matter. I mean, we give drugs for billions of dollars that reduce the chance of a stroke by 0.5%. Those are the blood thinners that we use all the time, like Eliquis. Catheterization, which they do without thinking, increases your risk of stroke by 1%. And they don't even tell the patient that. So everything we find leads to another test, another specialist, more money, more harm. And in the end, I don't know if you find this, Alan, but my patients come out of this misadventure in the hospital say, thank God that thorough doctor saved my life.
Well, the hospitalist is really one of the perfect examples of the Flexner-Osler dichotomy. Okay. The hospitalist theory is you have an expert who's there to take care of a hospitalized patient. They are taking care of a medical problem, not the human being, because they have no idea who that human being is, because they have no continuity relationship at all. They're not going to have a conversation about what's going on in their life and the psychosocial components and what happened to get them to this hospitalization. Wherein me and Andy have 35 and 40-year continuity relationships with our patients. Okay. Not saying I don't use specialists to take care of my patients in the hospital. I do. But I am my own hospitalist because I know my patient for all of those years. And that information, the history, the years of rapport, the relationships, the communication, the trust that is built versus a stranger taking care of you and doing 50 tests. I think it clearly shows that a mix needs to be there. I need people to know, because I hear it from some of my colleagues, like, you don't think there's anything about evidence-based medicine, and it's not true at all. We believe in the real evidence. If it's real evidence and it's proven, at least as of today, by non-pharmaceutical studies, because that's what it all is, and not just one study by the pharma company, but multiple continues to show that it's good, we believe in it. But if it's not, the Oslerian way of taking care of a patient is just so much better. We just can't forget the art of medicine, Andy.
And you know what? We also, like, we talked about the BNP, the test um, for the fluid overload, congestive heart failure. When my dad was in the hospital, they did a BNP on him, and it was really high. Yeah, he has a low ejection fraction. He always has a high BNP, and they start pulling fluid out of him. Well, I came in the next day and talked to the doctor, and the doctor literally said to me, "Well, there's a high BNP. The cardiologist agrees we need to do this." I said, "Have you talked to my mom?" I said, "My dad hasn't had anything to drink for like 2 days. His blood pressure is almost unmeasurable. The reason he's here is because of weakness, not any fluid problem. He could lie flat in bed, clearly doesn't have any swelling, doesn't have that." And the doctor said this, which was the most striking thing I've ever heard. He said, "Look, we don't have time to customize care for each patient." That's actually what he said to me. I was utterly shocked. But he was honest in what they do every day. They don't have time. All my patients who go to the hospital, we beg, plead for them to get in touch with me. Please get in touch with me. I could tell you some of the history, what we've done already. They refuse to do it. They said, we just don't have time to talk to the primary care doctor. Often they do tests we've already done. Often they go down a road we know is a bad road for that patient because I know the patient so well. We've done this before. We've tried it. We've had our fits and starts with that. They don't care. They just throw the whole gamut of medical technology and specialization at the patient. And yes, specialists are important. Someone comes in, breaks a hip, I'm going to get an orthopedist. I'm not going to try to fix it myself. I mean, there are times I need help from specialists. But the way the specialists are supposed to work is to help us with a problem and then be gone. Not to continue to follow the patient unless you have cancer or something, which is a different story. But they
And
just grab you and hold you and do more and more testing.
And the hospital's biggest report card, one of their biggest grades is on something called length of stay, how long the patient is in the hospital. Because the quicker they could get the patient in and out, and hopefully not come back within 30 days because that's a CMS penalty, but in and out, the more money the hospital gets paid because they get a fixed amount for, let's say, a congestive heart failure diagnosis, whether the patient's there for 5 days or two. So if they could get the patient out in 2 days, their time length of stay in the hospital is lower. The hospital makes more money and is happy with these hospitalists as long as they can make it for the 30 days. If they get admitted on 31, it's okay, but not on 30.
It's not only okay, it's ideal. You
Right.
get a whole new bunch of money. I've had patients though that like they go in for congestive heart failure. They get fluid taken off them, then they have a catheter put in, and then they get weaker, and then they feed them and they aspirate fluid into their lungs. Now they have a new diagnosis. They have diagnosis number two, which leads to more money. And the other thing they do is put people in observation for a few days where they get money for those days before they admit them. There are all sorts of tricks and how they could. And by the way, just like the hospitalist is owned by the hospital, the specialists in my hospital are owned by the hospital. The machines are owned by the hospital. So the more they could feed out people to specialists, even if they leave within the window, now they have money they're making outside the hospital from that hospitalization. People think we're too cynical, but we've lived in this system and we see the games they play with people. And it's almost like the caring of people is secondary to the to playing the games.
Again, hospitals are not all bad. If you get shot, if you're having a heart attack, you're having a stroke, please go to the hospital. They will save your life. We have
Yes.
great technology to do that. But if you're there for one of these complex medical problems, don't go there to begin with. Prevent what you have. And, we're going to talk about it in one of the next blogs that we do here about what we could do to prevent all of this crap from happening to people.
Yeah, I think that's something we'll talk about next time, right? Is prevention.
Yeah,
We'll talk about that next time. But yeah, again, we talk a lot about this in the book. The hospital, a lot of people say is the third leading cause of death in the country. People have estimated between 300 and 500,000 people die every year from things they do to you at the hospital, whether it's getting an infection, medical error, or overtreatment. Those are the three biggest causes. We've talked about some methods of overtreatment. Or on the other hand, if you have an appendix that ruptures, if you have acute, belly pain that hits you, if you have a heart attack, we have the best hospital system in the world for that. You go in there and get fixed. But if you go in there for something vague, you're going down a very bad road, and you're better off working with your primary care physician, nurse practitioner, whoever you see in that situation. This feeling that going to the hospital is the most aggressive and thorough thing to do. Thorough, in my opinion, is that you thoroughly speak with and understand the patient. Thorough is
absolutely.
not throwing a lot of tests and drugs and other things at the patient.
High touch, low tech.
Exactly. So we will talk next week about some of the things you could do to avoid going to the hospital. Any last words, Alan?
Uh, Keep yourself healthy. Keep yourself out of the hospital unless it's truly an emergency.
Yes, absolutely. Okay, I'll see you next week.
Take care.
Bye.
Have a good week, everyone.